This is a podcast that focuses on different musculoskeletal health problems, and we're looking at it from two different perspectives. People don't want to hear about what the doctor's got to say. People want to hear about the movements.
Obviously, everyone's trying to approach things through a medical lens with the best practices, evidence, and all that. But there's going to be variation and nuances to what people do.
Hello, everyone, and welcome to the Joint Effort Podcast. I'm your host, Dr. Saqib Hassan, an orthopedic spine surgeon. This is my co-host.
I'm Dr. Rob Lynn, doctor of physical therapy, strength and conditioning specialist, and owner of the Technique PT in Berkeley, California, where we work with active people and athletes to excel in their performance needs.
There's not enough podcasts right now. Not enough.
There's not enough. You can't get enough podcasts, especially podcasts about what we're going to go into, which is
I think we're the only podcast featuring a spine surgeon and a physical therapist, right? Am I pretty right?
That's I've never heard of that before.
It's different. I'd say that. So we got that one going for us.
It's one or the other.
And I think the bottom line is we're just two fun guys trying to explain things that are very complex and very relevant to your life. And hopefully this will be very beneficial for you in just being able to live a more pain-free life with less injuries.
And you hit a point earlier, not in this podcast, but we were just chatting about it, that there's so many people that don't know really the details of what we do, what goes into our thinking process, our exams, and our treatments, why someone should see a surgeon versus a doctor of physical therapy, etc. What even our backgrounds, you know what I'm saying?
Yeah. As a physician, I know a certain amount of medicine, understanding it, but there's a whole world of knowledge that I don't really have, which is what happens with the natural medicine of movement and physical therapy. And I think that's why it's important for Rob to kind of let me look into his world and he can look into my world.
Well, I mean, why don't we know each other because we used to be colleagues and we still have a relationship where we treat people in collaboration at times. But I don't even know your story, man. How'd you even get into this? What interests you in becoming a surgeon? You know, give me the scoop.
I mean, I think first of all, I'm a nerd, so that's just I like physics.
Duh.
So for me, that's just a weird thing that I think I don't want to be like a physicist, but one thing when I was in medical school, the only specialty I think in medicine that's all about movement and physics is orthopedic surgery, because we're pretty much understanding the bones, the ligaments, muscles, tendons, things can go wrong and how we can fix it. And I think it's amazing to me how I can do something with my hands and with the knowledge that I have and use that to fix someone. And all of a sudden, the thing they couldn't do, they can now do. And I think that's why I did it. What about you? Why did you go into physical therapy?
You know, I was a patient myself. You guys will hear, what kind of mindset you need to be a surgeon and a physical therapist. But in fourth grade, I was at the park, climbing trees with other kids, and then got up to this one tree about 15, 20 feet high. Then all the other kids were jumping out of it, and peer pressure will get you. So I jumped out and I landed on my own knee. My arm hit my knee, and then my arm was bent in half. So I fractured my ulnar radius. And then it was a whole process, and I missed camping that year. And I ended up going to physical therapy for the first time. That was my exposure. And then since then, I was always an athlete. I was on all the basketball teams. And then did Muay Thai, and there's a lot of injuries in Muay Thai. So I'm always going through injuries, and I always, saw the recovery process from that end, and I wanted to help people. What were we doing? We're doing some Muay Thai pad work one day, and we're like, hey, dude, let's start a podcast so that people who are active get more information and know the right choices to make so that they can keep doing the things they do. And then you were like, yeah, Rob, that's a great idea. And I was like, I know.
That's not what happened at all. But I do like where your head's at. All right. So bottom line, this is a podcast that focuses on different musculoskeletal health problems. And we're looking at it from two different perspectives. From a spine surgeon who's going to kind of represent the medical world, medicines and interventions, and then a physical therapist who's going to recommend physical interventions, which I think is the craze right now, right? The craze is is natural stuff, physical interventions. People don't want to hear about what the doctor's got to say. People want to hear about the movements.
Well, yeah, I think there's a disconnect sometimes when medical doctors refer people to PT. You're telling me you don't even know what goes on there. And even in our field, there's a lot of differences between providers. Obviously, everyone's trying to approach things through a medical lens with the best practices, evidence, and all that. But there's going to be variation and nuances to what people do. Traditionally, people just think of it as certain exercises. Oh, do these three, you're going to be all right. And we're talking about it. It really depends because as a doctor of physical therapy, they're training us to do our assessments and diagnose people on our own and come up with treatment plans for individuals. So it's not just cookie cutter. And I know what you do takes a lot of clinical expertise to come up with the right choices for people. We're really in this field to help people at the end of the day. And there's a lot of podcasts out there and you can get information from anyone, but after what we've been through, I think it's important that we share our background. And I'm never the one to say this is the only way to do it and we're the right ones, but this is one perspective for y'all. So enjoy it.
So I mean, I think you hit the nail on the head. I think that as a doctor, we're in medical school, we learn about all pathophysiology, the biochemistry, all that, the science, and then that's usually the science of interventions and understanding why things go wrong. I don't think we spend as much time on prevention, and I think that's just it's like the common theme in medicine. Medicine, for better or for worse, it's kind of focused on interventions that are medicine, involves pharmaceuticals and surgical interventions, which obviously involve your hands. So I think, and for me, half the time when we have to give treatment plans for patients, the treatment plans are usually, non-operative is a big lump for us, non-operative as a surgeon. And I really don't understand sometimes what's happening in the non-operative world, but I do know that it works. So I think for me, I'm going to learn a lot just understanding how you evaluate some of these patients and what treatments you recommend and kind of understand, what's the reason you do some of these exercises and these customized plans for people. And I think I can get a little bit more into your world.
Yeah, and we're gonna get deep into your world as well.
Oh, really? Are you?
It goes both ways, baby.
Dirty. Yeah. Okay. Anyway, let's just.
That's a weird pause.
Let's just. Yeah,
don't look at me. Don't ever look at me like that when you say that.
That was a weird pause. I agree with you. Can we cut that out? All right.
No, actually pause it and then drag that out longer, and then zoom in on our eye contact.
Let's not do a good edit. Okay. Anyway, so let's focus on today's episode, the first episode of the podcast. We're going to start with something that's near and dear to my heart, and that is the back. The first thing we're going to start off with is one question. Why should you care about your back, Rob? Why?
Well, we're here. You're a spine surgeon, and one of the most common reasons why people contact me is for back pain, whether it's an acute episode or a long chronic issue, whether it's mechanical or non-specific. It's a really common reason why people go to physical therapists, maybe go to Pilates, go to yoga classes, and we'll see the numbers. This is a big reason why people are on disability and things like that. And it's super complicated, but our spine is a large structure in our body. And there's so many attachment points to muscles that, we have to be really in tune with our spine and how we move. So let's see that.
So if you look at the slides, I mean, it is like the leading cause of disability around the world. I mean, you can see that the actual incidence in the past 20, 30 years has really been going up. And the idea is that I think that the activities of our daily life now involve a lot more sitting, a lot more crouched over a computer. It's not upright activities as much. I know my job is a lot of upright activities, but the average person is sitting in front of a computer all day. We always see this slide of evolution, right? The Darwin slide that shows that we start off as monkeys and we end up having the same shape as monkeys.
Well, let me jump in here. Which stage of evolution do you think you're at?
I think I got the rake. I'm a raker.
You're a rake.
I'm a raker.
You're a raker.
I'm a raker. Right. I think. Yeah.
I'm like, wait, what's that pointy thing? That the third.
I think it's a dagger. I think he's gonna kill the second
That's
guy.
the Neanderthal?
Or the fourth guy.
Ooh,
I think we're getting lost in this one.
or whatever.
I think it's
ape that is.
commentary that our posture is getting worse. But I think, I'd say I think we're just getting lost in this. I think people don't care about this.
All right, let's go.
Let's keep
Just to throw
going.
something interesting in there. But on that point, we were gonna talk about McGill later, I guess. Didn't he have that diagram of how much load your back has based on the positions you're in?
Yeah, well, we'll definitely get into that. I think so.
Yeah,
I think I think what we want to really focus on, I think, for the audience is we're gonna try to make this because as Rob mentioned, it's super complex. This is an issue. I mean, understanding the back and the anatomy it's not like a simple long bone like an elbow or like a tibia or a femur. The spine is very complex. There's different levels of the spine. There's a cervical, thoracic, and lumbar. We're going to go into that. And I remember learning the anatomy when I was back in residency and I did my first spine surgery. I was just lost. I didn't know what was what because there's all these bones that have different shapes that we've never seen before. There's like four. It's very three-dimensional, right? And I remember I was doing a surgery with one of my attendings, and I swear, I think he was lost in the spine because he was there for 2.5 hours. He didn't know. Scary, right, guys? But he just didn't know. I think the anatomy was really distorted, and the spine is just a really hard anatomy to truly understand.
So when he got lost, how long did it take for you guys to find him?
I think he had to call a lifeline. He did. I think someone had to come in and show him. I think it was a pretty embarrassing moment for him, but he shall remain nameless. He'll remain nameless.
Shout out nameless.
So I think let's go back to just some basic understanding of the spine. Can we pull up the slide again? So I think the first thing is to understand the back and the spine, we have to understand what the function is. And the form of the spine is suited to its function, right? So what would happen if we didn't have the spine?
You'd be an invertebrate like this jellyfish from the Monterey Bay Aquarium.
Is it Monterey Bay?
One of the best aquariums. You should really go there when it's.
I think I haven't been there.
What are you doing?
I don't like jellyfish.
What is it about jellyfish that you don't like? Let's hear it.
They're spineless.
You can't do surgery on them?
I set you up. Yeah, it's like
you'd be out of a job if everyone was jellyfish.
They got the worst insurance. They got the worst. Jellyfish got the worst insurance. That's for sure.
For the being.
But movement, right? So let's say you look at so this is a nice if we just had the bones and discs. You see that's the spine. There's all these discs, right? So Rob, when you look at this, obviously it's missing a lot of the muscles. Why are the muscles important?
Well, with every with our skeleton and our spine structure, muscles have originating points and insertion points. So, the way our body works, they work together to get our body to move properly.
And another important part of the spine is flexibility, right? So you can see it's like a beautiful orchestra of the muscles, tendons, ligaments, the discs all working together to allow us to do things like that, which honestly, from my perspective, I don't think that's the healthiest thing for the spine. I don't know. What do you think, Rob?
Well, yeah, we could talk about that. I think you got to look at the individual. Our spine is meant to flex, extend, side bend, rotate, and combinations of those movements. You'll see acrobats, people who do contortion, dancers, they'll have more mobility than others. If you took a normal person and told them to just bend like that beyond their capacity, I think that could be an issue. There are people with things like EDS that can easily do that. But it's interesting. I think you got to take it on a case-by-case basis. I'd love to know if you've seen any research and in your experience, how frequently you might see, say, a spondylolisthesis, a spondy happen with that group. What is your thought? What is that? Anyone explain to people what that is?
So first thing, spondylolisthesis. I don't want to go too far off topic, but that's when the spine slips forward. People call it like a slip disc, right? So slip disc, and we've seen that and a higher incidence of spondylolisthesis from a different reason, from what's called a pars fracture or stress reaction in one of the bones. We'll talk about that a little bit later. In fact, we'll probably have a whole episode on spondylolisthesis. I think that's a really important. It's a really big topic. But I think so. Yeah, there's certain activities that you can do that will actually put your spine at more risk for injury. And the way I look at it, if we go back to that flexibility, that yoga master, I think from my perspective, I think that the spine, and this is a very broad statement, probably a loaded statement, that it's really more meant to stabilize your body in certain movements. So your core is, spine's part of the core. So the muscles that surround the spine are kind of activated to essentially allow you to perform functions of your body without putting too much strain on the muscles, tendons, ligaments, and discs of your spine. So, long story short, I would say that patients who kind of push their body to the extreme, and from my perspective as an orthopedic surgeon, is that I end up seeing these people towards the end when they've done all this stuff and it's burnt out, right? And they have all these disc problems and ligament injuries. So I think that from what I tell my patients is it's better to kind of stay in the middle. Don't be too extreme with the lifting and don't be too extreme with the flexibility, because I think that some people can do that. And you mentioned, EDS, which is Ehlers-Danlos syndrome. There's a whole, group of collagen disorders, and a lot of patients with collagen disorders, they can end up having more flexibility. And you do that test where you take your thumb and you bring it down. I'm not flexible at all, but I think that. What, you got something to say? You got something to say?
I was gonna say, anyone in this room have EDS?
Oh yeah, we got our producer Jazz, my fiance.
I just called her out. Let me cut that out.
Yeah,
I'm not supposed to be calling people.
My fiance is an EDS survivor. Actually, I tell her that she's all flexible and whatnot, but she always she's putting her hand in her face right now.
We'll cut that part.
She's an EDS survivor for sure.
We're cutting survivor.
So
I think you should play that. I'm a survivor. I'm a.
We're gonna play that
when you say that. We're gonna have that in.
Okay, but bottom line is like you mentioned, there's these collagen disorders, and some people are more flexible than others, and that makes them think that okay, yoga's my calling because I could be so flexible. Really, your flexibility is kind of I don't want to call it a disorder. You can call it maybe a mutant superpower. I don't know what you want to call it, but the idea is that the collagen is different. It's different from the average person's collagen. And a lot of the tendons, the bones, the ligaments, disc, all this stuff has collagen, right? And collagen is a flexible tissue that allows your body to deform without essentially having a permanent deformation. So, there's all that stress and strain and all that. I won't get into that. It's too much physics. And I'm sure no one cares about that stuff right now. But the idea is so the bottom line is flexibility. It's on a case-by-case basis. And when you see someone and you're judging their flexibility, what are you looking at? Like what's good flexibility, what's bad flexibility? How do you balance that with muscles and strength? What do you tell your patients?
Yeah, well, there's norms that they teach us in school and for all the ranges of motion for each joint, right? But we do look at it case-by-case basis because a dancer or somebody like that, their norm is going to be different than someone else. And you have to make that decision. And talking about risks with these movements, yeah, people have to make at the end of the day, risk reward analysis of what they're doing. If you're doing that professionally and that's part of the job, then maybe we got to find out ways to do it safer. If somebody is more mobile, we're not, likely we're going to spend more time working on stability with them and how to create that tension and stability in those positions more so that they're safer when they do the exercise rather than just limiting people and just saying don't do it. But everybody's different. You might tell someone not to do something, they're still going to do it. And if they're capable of doing it and they need to do it for a job, that makes it a little more complicated. So that's my take on it.
So, we talk about Stuart McGill, right? He's like the guy that a lot of people refer to when they're trying to understand back mechanics. He has that book, Back Mechanic. And, he kind of like breaks down like the yoga master or yogi and like the power lifter, right? And I think that do you think that, first of all, what's your thoughts on Stuart McGill? Because I think that, as a spine surgeon, again, I don't know that much about the PT world. I know that physical therapy, it's an option for the patients. And I say, okay, you got to do physical therapy. And then I send him on the therapy in the therapy direction, but I don't know what they're exactly doing. But I trust that my therapist is going to be doing what they need to. But I don't. When they ask me questions, I kind of all I do is, well, you need to have a neutral spine for most activities. And I do the basics. But what's your thoughts on McGill, and how do you take into things that Miguel might talk about and incorporate into your practice? Do you feel like they're only partially relevant? So tell me.
Yeah, I mean, shout out McGill. He's a big name. Obviously, if you've heard of him, and I think he's known for his big three exercises. He's done a lot of research on the spine and loading it and things like that. There's a lot of schools of thought. You'll hear about other names like McKenzie, who's extension based for some of these pathologies, and also throw some other guys out there, Gray Cook, Mike Boyle. I mean, I'm influenced by like all of them in different ways. So, not to, I'm just shouting them out, respect to all of them. But I think that looking at things in a very simplistic form isn't always the answer, because people do come to me after they've been through everything, and say, hey, like I'm just doing the big three or whatever. That could help a little, but it usually takes more. So that's my thoughts right there. But it's great information, and at the end of the day, as a clinician, we always have to make our best clinical decision and look at the whole picture, because it's never that simple.
It's funny you mentioned that. Like you said, like you're influenced by this guy, that guy, this guy, right? It's funny because it's kind of like like an artist, right? Like you have all these. Oh, I was influenced by Tupac and a little bit of Biggie and blah blah blah, and maybe a little Wu-Tang Clan. That's all. Dating myself, '90s reference, obviously.
Shout out Tupac.
Shout out Tupac.
What's your favorite Tupac song?
Oh man, it's got to be Hail Mary. I'm sorry. we can't give Hail Mary.
I came out to a fight with Hail Mary.
Oh really?
Because that
most people don't know this, but Rob was a Muay Thai champion actually, and in a previous life he was in Thailand winning belts.
I didn't win them in Thailand though.
Oh, you didn't go to Thailand?
I did, but I didn't win any belts in there.
They wouldn't have found out. You should have just said you did. This is your chance.
But hey, yeah, that's a good song. You're right. Shout out to Tupac. Hail Mary. Mine's is All Eyes on Me.
but right, so the artist. So I think the idea is that.
But I digress.
Yeah. So I think that there's something about physical therapy, which is we always say there's an art to medicine, there's an art to all these things, and I think with surgery there's an art to that too. But I think that there's more. I don't want to say there's more art, but the art to physical therapy is really. I think you mentioned this before. How I think it was the Academy of Physical Therapy. What is it called again? The
APTA.
APTA. Yeah. So they talk about how they grade, how they define what the recommendations are, right? Because a lot of in medicine we just are based on evidence only, evidence-based. What does the best research show? Is it a randomized control study? Is it double blinded? I mean, what's the risk of bias? We're all very science-based, but I think that with physical therapy, there's so many more elements. Just like there's a lot of elements to medicine. Talk about the elements that you see with patients and what you're taking into account when you're evaluating them.
Yeah, that's great. I just want to throw out there, in PT school, I went to NYU. I don't know if every program did this, but there in that program, every semester we had to do, we had to look at the research. Also, we had to take a class that basically just helped us understand all the research and evidence behind everything, and that was every single semester for the entire duration of the program. So we did have to look at that, the P numbers and all that.
It's all about the P numbers, right?
There was like a Pedro scale that rated how good things were. And so when I do I do my own research all the time, but that you're right, it is only a portion of it. When you look up in the APTA what evidence-based practice means in physical therapy, it's equal parts the best available research, your own clinical experience, and also the patient's values. So that leaves a lot of room for nuances in how you treat someone. You can get really stuck on these things and use a paper to justify what you're doing too,
Yeah, I think that's important, because I think that, right now in the world, there's a lot of people who I think look at, I guess, academics, or I guess you'd say kind of the experts, and there's a lot of movement to discredit them. And that's because you can discredit some academics by looking at the risk of bias in research, and there are obviously sometimes ulterior motives in research. But I think for the most part, most research is done with the idea of the love for science and trying to understand, is an intervention actually working, or is it just something that really has no effect, or that p-value is way too high. P-value is way too big.
That p value.
So, but let's just, I don't want to digress too much. Let's talk about anatomy. Can we pull up the slides? Yeah, there we go. So spine anatomy, I think, first let's just get, I think the spine, like we talked about, is very visual, right? To really understand the spine, you have to really understand the anatomy, to understand the back. The back is part of the spine. You have to understand all aspects of it. So very briefly, there's cervical, there's a thoracic, and then there's lumbar, and there's sacral, right? There's all these bones that form together through discs and different joints called facet joints, and they form the bony skeleton of the spine. Now I'm actually going to pull that up, and all right, so we got our beautiful skeleton model going, and we're just going to kind of, like I said, I think this is important because we could talk about this all day, but like I said, for me, you can read about this stuff, but unless you see it, you don't really know, you don't really understand it. So let's talk about the spine. We talk about different parts of the spine, right? You see right here, we talk about, that's the facet joint right there, right? And that's more so, you can say that all these joints participate in motion, but the facet joint is more axial rotation, right? So and then you could talk about the next part of the spine, which is going to be the disc. And then we're going to spend a lot of time on the disc. And I think the idea with the disc is that I personally think it's the source of most problems in the spine are from the disc, if that makes sense. But I think there's also other parts of this. Obviously, there's the muscles, right? Hold on, let's just zoom out a little bit. Okay, so let's talk about the muscles, Rob. So you're the PT. Let's talk about some muscles.
Let's talk. Talk to me.
So how about this? When you think about the most important, when someone's working out their back, right? And they're working out their back, what muscles are they really working out? Are they working out these little tiny muscles that, they're going from transverse process to transverse process? Then you have obviously the muscles that go, these are the small, we call them stabilizing muscles, right? What are the stabilizing muscles important for?
Yeah, there's a lot of muscles, and you can put on all the layers. You got the deep muscles, and then you got the superficial muscles. There's layers upon layers of muscles, and all muscles have an origin and insertion. They act to move you in different directions. So if you talk about when people say work out their back, I think that can mean a lot of things because obviously you're looking at all this over here. Erector spinae help extend the back, right? You got lats too. People think of lats as their back, but the important ones that you'll hear PTs talk about are multifidi muscles. You can pull that up.
Pull the multifidi. It's funny. Talk about the multifidi. So these are the multifidi. A lot of times in spine surgery, what we consider minimally invasive is when we don't disrupt the multifidus muscle. Because I think that, at least in spine surgery, when we say minimally invasive, the idea is we don't want to strip off all these muscles. When you talk about spine surgery will be a very different episode, but the idea is that with some spine surgeries, you actually strip all these muscles off. And the multifidus is a very important muscle. Why is it important?
Well, the multifidi helps stabilize your spine, right? That if you look closely into them, they're connecting each vertebrae to each other.
Mm-hmm. Like you see, that it's like it makes the spine move as one unit, if that makes sense.
Yeah. They act to stabilize the spine. So bird dog exercises are supposed to be one of the exercises recommended to help stabilize and activate that muscle group. Deep ab, and that's one that I train people on how to activate. We can talk about that in a different episode. But that's beneath the six pack, right?
Yeah. So I think that's really important. I always tell people everyone's got a six pack. You just can't see it on everyone, right? That's the rectus muscle. You see all these muscles here. That's a six pack, right?
Right.
And then you have obviously you have muscles that cross the joint, right? So you have the psoas muscles, right? You have the psoas muscles like right here, and then you have all these other muscles, right, that go up the quadratus lumborum, right? So these muscles, this is why when you talk about it as a therapist, you're putting it all together, right? Because when a muscle crosses joints, you can use a leg muscle and activate your back muscle.
Yeah, so you think of core too. We think about the glutes.
Let's
Glute
look those up.
max, glute med, glute min.
Right.
Right,
These are the
those
glutes right there, right?
gluteus medius is an important one because it helps keep your pelvis stable, and that relates to your spine in so many ways. Trendelenburg sign. What you
Hmm.
know about that Trendelenburg
I'll tell you, you know
sign?
what? I'll tell
What
you
you
a
know
story
about
about. I'll
Trendelenburg?
tell you about Trendelenburg. In my residency, in our residency, we really went into detail with all the stances, understanding the muscular movements. We would our chairman would make us actually go in front of the whole residency and try to demonstrate a Trendelenburg gait. And I kind of call it a gangster lean gait, right?
Let's see it.
I'm not gonna happen. Not gonna happen.
Dang.
But the Trendelenburg gait, the idea is that if you have some of these muscles that are weaker, then the hip falls down when you walk, right? So that's that gangster lean, right?
Yeah, and we can talk about all these muscles as individual muscles, but in PT we also talk about slings and systems, and that's you can't just. It's important to strengthen isolation sometimes too, but ultimately you do want to look at your body as a system, right? So, and then we got the fascial lines too, and that's
Yeah,
that's a
it's all
whole
the.
nother thing to look at.
Let's
So
add some more
we can get into
fascia.
that,
So this is all the
later
fascia. You
too.
have all this fascia here, right? Sometimes
Yeah.
I think when someone throws their back out, they might tear some fascia, and it's really, we're going to talk about throwing your back out, right? But how many times when people have these acute back episodes, do you think it's the actual muscles, tendons, ligaments? How do you, as a PT, try to figure out? Well, because for me, sometimes I look at an MRI, the MRI is completely normal, and they're having this, back pain that's kind of radiating, and the discs look pretty normal. So from my perspective as like a spine surgeon, I'm like, well, there's no functional problem with the bones, ligaments, tendons, and no nerve impingement. But then how do you look at these muscles and say, okay, well, you might have, like, I could say, for example, every time I try to take my jacket off in a car, put a jacket on, I swear some muscle in the back of my rhomboids, I feel like it just kind of, it gives you this sharp pain. And a lot of times people ask me about pains like that. And sometimes I don't have an answer because it's not my realm. So what do you do? How do you figure this
Yeah,
stuff out?
pain is complicated, right? We can go into all of that. You talk about the anatomy of things, and we can get into that other book you said, McGill. There's Explain Pain. It's a good one to a
Yeah.
little read. But so as a PT, we do a full assessment too. We do the neurological assessments. We're very competent in understanding the nervous system, how things connect that way because every muscle has a nerve innervation to it. Has blood supply to it. You got to know the pathways of these nerves. So we can test all these things. There's tests we do, straight leg raise, sit and slump test. That'll test sciatic nerve and discs and things like that. So we rule a lot of things out, and a lot of the tests we do, they're not, we'll get information sometimes with the MRI. Sometimes it might show a bulge disc, but a lot of times that's not responsible for the pain because people without symptoms can have things like that. So it gets complicated. We do a full assessment on range of motion. We do the neurological tests. We also look at how people move. I think that's really important, right? Is the biomechanics and how people move, because at the end of the day, that could dictate how people why people are feeling some of these things.
And you mentioned the MRI, right? I think that's an important point to make is that a lot of times MRIs can show a lot of problems. And the important thing to understand is that almost like 40 to 60% of people over a certain age, I think over the age of 35 or 40, are going to have some degenerative changes, some disc bulges, some arthritis. And honestly, I just consider that part of just the wear and tear of life, right? That's just called life. That's
Life will hit you hard.
yeah, life will hit you hard. So I think, well, the MRI is going to show you, just signs that you lived a normal life. No one's going to have
Yeah.
like an MRI that's like when you were 25, right?
Right.
Or 20. You're not going to have that same MRI. And that's normal. It's like having gray hair. Sometimes gray hair can be sexy.
Silver fox over here. But you're right. In PT school, people don't know this, but along with learning about the research, critical inquiry was the name of that class. We had to do that all the time. We had to take the radiology class, pharmacology class too every single semester, as it paired with whatever system we're learning about. So we have a rough idea of that too. Take it with a grain of salt sometimes. just more information, but we try to look at the big picture and use all this to decide how we're gonna treat somebody. Obviously, it's not simple. And you asked me about the art of it, right? The art of PT. You know the slogan of PT though. Speaking of art,
What's the slogan?
it's the science of healing and the art of caring.
Wow, look at that. It's deep, man.
Because I
I feel
care.
like
Man.
I feel the human connection there right now.
Here, give me a low five.
Oh, we're doing low fives. Okay, here we
One,
go. Let's see if we can time it. Ready? One, two,
2, 3.
three. See, my neuromuscular control is not as good as yours. I need some more PT. I think I
Let's
can't.
do it. I got
can't.
you.
I can't do it like you do. Anyway, so I think that one thing we want to talk about is I want to talk about something that's very important to what I do, because I feel like, I think I mentioned this before. I think a lot of problems that people attribute to like back pain and non-specific back pain, a lot of the times it can be traced to the disc. And I think it's time we talk about the disc. Let's pull up the slide. There we go. So when we talk about the disc, we have to understand a little bit more about what the disc is. And this is a nice picture. So the disc is, I'm gonna draw on this a little bit. You can see the disc is this kind of scallop-shaped structure, and it has this thing called the annulus fibrosus on the outside. Think of it as like tightly woven threads of collagen that
Yeah.
essentially are around the disc. And then you have this gooey center called the nucleus pulposus. And you can see this right here. That's the nucleus right there. You see these kind of this meshwork of collagen kind of keeps that in the center. And the disc is important because it essentially is a load transducer in the spine. And we're going to talk about that a little bit later. But essentially, because it's filled with that gooey center.
Well, you're making me hungry talking about scallops and gooey things, first of all. But yeah,
You mean
they're
scallops?
I was waiting for that picture. Yeah, they're made of different. It's made of different material. Correct me if I'm wrong. I think the outer layer is more collagen, and nucleus pulposus is composed of more proteoglycans.
You just wanted to say proteoglycans. You've been waiting
I've
all
been
day to
waiting
say
all
that
day to
word.
say that. Go on.
Proteoglycans, if you want to know, they're kind of the proteins that hold water very well, and that's why you can have high hydrostatic pressure in your disc. And the idea is, so I have this picture of scallops because honestly, the closest thing I can tell my patients is what a disc is like a juicy scallop. Put a little lemon juice, a little garlic.
Drizzle a little of that olive oil on there.
Hannibal Lecter. You think Hannibal Lecter would eat discs? You think if Hannibal Lecter ate discs, he'd put garlic and lemon on them?
Let me tell you something about the spine. I love bone marrow.
Oh my god!
I love, spread
That's
that
long
on the
bones though.
toast.
I don't think you're eating spine bones like
I'm
that. I
eating,
think
I'm
you're eating
eating
long
stem
bones.
cells.
You're eating stem cells.
All right, but we digress.
But yeah, so the disc, right? So when we talk about the disc, we talk about the aging phenomenon of the disc, right? So a normal disc is kind of like this, has this juicy center, and it can really hold hydrostatic pressure. But over time, that disc is going to shrink. It's not necessarily that disc is a problem. It's that the water content of that disc shrinks, and essentially the disc will stiffen over time. That's why when people get older, they might not be as flexible. And part of that is because the disc is essentially desiccating. That's a fancy word for just saying drying out a little bit. In fact, did you know, Rob, that almost 20 to 30% of your height of your vertebral column is from your disc? So
yeah, I know. So I think I was like 6'2" a couple years ago.
Oh man, bad disc issues, right? That's some bad disc issues. Well, we could fix that. When we do spine surgery, we can actually make you taller, right? It's called cosmetic spine surgery. That's a lot of guys.
I thought they do that on the femur.
We do it on females too. If you want more, you want that more lordosis, you want more curvature, lordosis. That's the key word here. Okay, so I couldn't not show you an actual disc from surgery. You're not a spine surgeon unless you got a phone full of disc pics.
Perv.
You gotta say that. Hey, I mean, it's just spine jokes.
Oh, you said disc.
So anyway, I want you to look at this. This is actually from surgery. We had to take this disc out because the spine was unstable and the patient couldn't get their core stronger. So you had to take the disc out and we replaced it with a metal cage. And talk about fusions at some point one episode, and this is from a discectomy. The idea is that disc degenerates over time. Sometimes it can come out of the annulus and cause pressure on nerves. That's where I enter the picture if the physical therapy is not working. And again, we'll talk a little bit more about that. But I think again, the idea is to understand your back. You need to understand physics. Yeah. We're going to talk about the disc and how it's a healthy, how the healthy disc can essentially transduce a significant amount of force. So if you think about what's the tire pressure in your tires in your car?
Well, I got that 4Runner, and then I changed out the stock wheels and got the big boy tires on them so I can go off-roading, but I never do. So I don't know what they are.
I'd say they're anywhere between 30 to 50 psi.
Okay.
Right? Because when you fill it, that's what the computer says. But a healthy disc can take up to 290 to 400. That's almost 10 to 15 times the amount of pressure in a actual tire. So that means that the disc can tolerate a lot of compression forces. So is it that like lifting weights is causing disc problems, or what do you think is really causing the disc problems? Because if the disc can tolerate that much, that means there's other things at play. It might not just be the compressive force that causes the problem. And I think that's where Stuart McGill really did a nice job of showing the physics behind it, right? So it's not just the axial load, it's the physics, right, of the torque and the lever arm on the amount of pressure you can have on your disc. You can see these nice pictures. 40 kilograms translates to 400 kilograms. I know that in pounds, about 700, 800 pounds. And that's a tremendous amount of force on your back, right? So what do we tell patients? We always talk about no BLTs, right? So why is that? Is it because of this?
Like if you look at diagram 1 versus 2, right away you see diagram 1. The man is hip hinging properly with the neutral spine.
Hip hinge, you see that? That's the hip hinge.
And that's one of the things I like to teach with people. Not to say your body shouldn't flex and be able to carry that kind of load sometimes, but the hip hinge is probably the more biomechanically safe movement in many ways. That's how you squat. That's how you deadlift. I always tell people when you're doing a hip hinge, and there's so many different ways. You might have that neutral spine, but your nose is too far forward. I always say if you're dripping snot, make sure that snot drips between your feet, not like 5 feet in front of it. Sometimes what I'll see.
That's pretty gross. You tell your patients that?
Yeah.
Well, I mean, this is a nice little video showing like how not to lift a box, and I want to harp on this. I mean, it seems so simple. Everybody knows this, right? Don't bend with your back, bend with your knees and hips, right? But you should really understand that when you bend with your back, you're pretty much doing a disservice to your discs. You're putting so much load on them unnecessarily. And if you really need to bend, I mean, why not bend from your hips? And if you need to bend from your back, I think the best time to bend from your back is if you're doing like prone or supine yoga, if you're on the floor, you're kind of taking gravity out of the equation.
Yeah, it gets complicated too. Have you ever heard of a Jefferson curl?
What's a Jefferson curl?
Pull that up.
All right, so we got the Jefferson curl here. What is the Jefferson curl? What are they? That doesn't seem right.
Well, that's loaded spinal flexion. And I think the reason why some people do this is to gain range of motion by loading it. But just like anything, if you're exceeding what your body can handle, that's when injuries happen. I've seen a lot of people also do this really safely if you have the right progression to it. But
so this is kind of balancing stability with flexibility. I mean, I guess I would tell my patients never do this.
You wouldn't just load it like you wouldn't throw 45 plates on it and start doing this right off the bat. But yeah, it's a case by case scenario. Like if they have pre-existing history of things, I probably wouldn't do that off the bat. If you do it in the right way, you could see some benefits. I personally don't do that a lot, but we do teach people how to flex and extend their spine. Normally too. It's not something you should be fully scared of, but if you're picking up heavy loads with the wrong technique, you're probably going to be at more risk for injury. You don't just like jump into something like that.
Yeah, I think I see patients when they're seeing me, they've done a lot of things already, right? So when they're seeing me, all the things that they've tried with therapy and whatnot have not been working. So usually at that point, their discs and some part of their spine has already been compromised. So I typically wouldn't tell my patients, if you're my, if my patient's watching right now, don't do the Jefferson curl.
Yeah, well, yeah, the people that get to you at that point have a lot of factors there.
Well, I do want to show one little thing here. I think it's another important thing that people want to take away from this. We talk about compression loads. We talk about flexion loads are not the best for the spine. But one thing that should be talked about, and you can see from the biomechanical study here, that this shows load to failure. Oh, go back a little bit. I'm going to show this right here. Shows load to failure right there. If you see that number is really low, right? 31 newtons versus 45 or 1,000. So the top ones are compression, meaning the disc can take a lot of compression. The disc can't really do that well with rotation, right? And we talk about rotation. Let's just show that one real quick.
Well, one thing that I'm curious are how this study was done. Was this done on a cadaver or in a live person?
Well, this is a cadaver, right? This is a cadaver. So, I mean, obviously, it's hard to test these things. You can't really have biomechanical testing on someone unless you sticking all these like force sensors inside their discs. It's just, and the studies show you even put a needle in a healthy disc and it can cause degeneration. So obviously, we're limited with the amount of data we can get from. So I imagine that obviously these loads are probably a lot less if you have a good. If your brain is on and you have that whole other system going, and you have like
something
the muscles activated, right? There's a good point. I think a lot of the research we're going to sometimes talk about, it's in vitro, it's not in vivo, meaning it's not in a live person. So it's hard to make these biomechanical comparisons without really understanding how the muscles play into this, and that's why a therapist is so important. And the brain, the neuromuscular stuff. So explain the brain stuff. What's the brain stuff about?
Well, at the end of the day, that's our higher control center, and that's responsible for how we move, how we respond to things, right? We get signals into the brain and out of the brain, and your muscles aren't just acting alone.
So neuromuscular control, right? Everyone talks about neuromuscular control, proprioceptive feedback. These are all things that are PT keywords that I always see in the PT note, right? So explain that to me a little bit. Explain to me like I don't have time to listen to the whole thing.
Well, just having control of your movements in different motor patterns, neuromuscular control, it's like a general term for basically a lot of what we do is neuromuscular re-education. You'll see that as a billing code in some of these things. But yeah, it's getting your brain to control how you move. Sometimes, whether it's like a stability exercise, balance exercise, coordinating movements, that's all controlled by your brain, not just the muscle alone. In short,
so we always talk about how with patients, some people are have a mechanic mind and they understand how their body moves, right? And some people don't, right? And they just have a trouble coordinating their body movements the way they want to, right?
One of my professors would call people motor morons.
Yeah, that's it. So motor morons.
It's kind of offensive to some people.
You know what?
But it's kind of funny too.
Shout out that professor.
Shout out
for not caring.
No, she cared.
She cared. But the idea is, so we're just labeling people based on how easy it is for them to follow instruction. That's what it is, right? That's a motor moron, right? But I think if you look at this one right here, this is a nice picture of that axial rotation thing. So I think that we talked about the disc by itself is not so strong with this kind of axial rotation force. You can cause annular tears, which is, tears in the annulus here. So that's the annulus. Oops, we got that again. Let's get this. So tears in the annulus here, and then you can have the nucleus pulposus come out that way. So, usually most motions that are going to happen, that are going to cause problems, are going to be a combination of like a compressive load and a flexion moment, as well as a, rotational movement, right? So, like, for example, I have a lot of patients who are golfers, right? A lot of my patients play golf. And, if you're not the best golfer, I mean, I'm not a good golfer. I know we went golf a couple of times. We're getting there.
Montclair, shout out
Montclair. But the idea.
Shout out.
What's his name?
What was that guy's name?
Marty.
Marty. Tommy.
Let's not talk about Marty.
Let's
not talk about
Marty. Why? He taught you how to hit a ball in the driving range, man.
Marty had a cup. Yeah, Marty might watch this episode. Let's not talk about Marty. Okay.
All right, man.
Marty's a good guy. He's a good guy. Anyway, so in terms of axial rotation, right? That can cause all these issues. So a lot of times, if you're swinging really hard, you put a tremendous amount of axial load on your spine. So I tell a lot of my patients who end up having spine surgery, you have to change your swing a little bit. And I say, you got to go to a therapist, and you're not going to learn from me in 15, 20-minute visit where we're talking about how you're doing post-operatively. You got to talk to a therapist. You got to understand how to change your mechanics for the things that you love to do. Because part of what we talk about when I do surgery, it's not the end all be all. I'm doing the surgery to help you get past a certain point of pain so that you can prevent the future issue. So, you know,
that's great that you mentioned that's not the end all be all, because some people think they can just get a surgery and then that's it. And I've noticed you also say, hey, I'm definitely not doing this surgery or a surgery on you. You need to get another professional opinion, like a PT or someone to help with that. So that's really important. You talk about the golf swing, things like that, and all the axial load and shear forces too. That's another factor there on the discs. But there's a lot of components behind that. How you move, you might be lacking motion in one area, and then that ends up you compensate with other parts of your body. So it gets complicated, and that's good that you can refer out and send people over there. And there's people that get a lot of therapy because it's not magic sometimes too, and end up needing the surgery. I've seen that too. I'm not going to say that PT saves the world all the time, but you don't want to go into that just right off the bat. And but then they'll end up coming back and then get that preventative and rehabilitative approach. So when do you decide to do a surgery? What are the signs?
That's a loaded question, but it's a good question because I think patients need to understand that most spine surgery is elective, meaning that it's because the pain is so bad and you just can't do certain quality of life things. So you're kind of limited in what you want to do. So you're trying to improve your quality of life, and we define that as elective surgery versus necessary surgery or surgery that's kind of emergent is because if you don't do it, you will lose function in certain things of basic living. So for example, for me, if someone needs surgery, if they're having progressive weakness, the nerve is being strangled, by a disc fragment or a bone spur, we have to intervene so that doesn't become permanent because nerves actually don't do a good job of regenerating, right? So when someone gets paralyzed, right, spinal cord gets injured, that they don't really come back from that, right? So same thing with nerves. Nerves are special in that they can tolerate some degree of compression, but we call it a threshold disease where it's like the straw that broke the camel's back, right? After a certain millimeter of compression, the nerve can't take it anymore and it goes haywire, and you have the pain down your legs, the numbness, tingling, bowel bladder problems, all that stuff.
Yeah, I was gonna say one of the screening questions, like red flags, are do you have bowel and bladder issues? And if they do, you got to go to the ER right now, and that's like an emergency.
I don't want people thinking that if you have a bowel bladder symptom, you need spine surgery, because sometimes it could be like a pelvic floor problem. It could be a lot of things. So I think that, and a lot of times, the only time I really see when there's really bowel bladder symptoms is when the MRI shows really severe compression.
Yeah, and they wouldn't even be in my clinic anyway.
Yeah, at that point. Really I think the bowel bladder stuff is important, but I think it's not just minor bowel bladder things. Obviously, if you have really severe compression on your MRI and you're having bowel bladder symptoms, then talk to your surgeon, because that might be something where your nerves are being severely compressed. But other thing I say is, I tell my patients, well, if you, for at least the question is, when do they need surgery? Well, it depends on what condition is, right? And that's going to be, we'll talk about that on the surgery episode. But in general, I tell people, is the life that you're living right now, how long can you be willing to live this life before you feel like you've had enough of this life? Can you deal with this pain? Because honestly, time will heal most spine problems, because time and physical therapy and just the body healing itself will fix most of the back and neck issues that the common person will face. But it's when that time is taking too long, right? That, it's been a year and a half. Well, how much life did you lose in that year and a half? That's where spine surgery is effective and helping you get out of that episode. But then I tell my patients, surgery is just part one of your journey, right? Maybe it's part 2 or 3, but it's a reset, because once I do the surgery and I take away that pain for you, then the journey starts again where you have to learn to not keep having that. So if you have fusion, you have to change your mechanics, you have to change the things you like doing. So when I send patients, like when I send patients to you, what are they asking you? Let's say they had a fusion, right? And we'll talk about this a little bit later in another episode, but what are the patients asking you when they first see you? Because you have to ask what they want to do, right? What they enjoy. You said the value thing, right? With PT, what are you asking the patients?
Well, in the assessment, typically there's a little time frame before they even reach PT after some of this. But in my mind, there's always things that people can do, and even from the psychological component, it's important you empower people with safe things to do from the start too. It's not. Sometimes people think physical therapy is like, oh, they're gonna have me run and jump. Well, that's not the case right off the bat. There's different phases of it. Does that answer the question?
Yeah, I mean, I think kind of. I never understand physical therapy answers. They're always long-winded, and they're like, "Yeah, well,"
because there's no standard thing for everybody. And
I'm a surgeon. I'm like, is it herniated disc or not? I mean, is it causing compression? Well, there's different. I'm black and white, but
no, it isn't though. Is it?
No, you're right. I'm being playful. That's what I'm doing right now. Anyway, he doesn't like that. He feels awkward. He feels awkward. I'm being facetious. That's the word I want to use. Being facetious.
Nice.
Anyway, let's go to that. Let's go to the PowerPoint again. I want to show some things. So I think that this is like from McGill as the back mechanic, right? I think he just did a really good job of illustrating some basic things, right? Like from when I was in residency, we didn't learn about stuff like brushing your teeth and like, driving and sitting for long periods of time. So, in my first year, I was just noticing that people were asking me all these questions. I didn't know the answers because we learned about how to fix a problem, how to diagnose it, how to read the MRI, understand the biology. We understand so much, but this thing is so basic, and I just didn't have good answers. But so I did my own little journey, and actually, what I picked up is that, and this is an independent thought. I didn't see this before. I was thinking when people bend over to brush their teeth, because I knew I had a little back pain when I was bending over. I'm like, and I think about it. I'm like, why am I having some back pain when I'm bending over? Well, it's the concept that when you bend over, when you brush your teeth, you actually are putting a tremendous load on your discs. And it's unnecessary to put that load. I mean, and if you're going to put that load, you should kind of tighten your core. So I think this is nice. These diagrams show of the different activities that you can engage in. How about you walk us through some of these, Rob, and what you tell patients? Because I think these are basic things that, even if you don't have back pain and your back feels completely fine, you should probably practice some of these things, because just by, hip hinging at the sink and tightening your muscles, you're actually doing a little bit of workout. Are you not?
Yeah. There's a lot of ways to do things. I actually am of the philosophy that for every movement, you should know how to do that movement, several different ways. Have a bit wide movement vocabulary,
Yeah, I mean,
a dance teacher actually. She was a movement specialist that I worked with, and she used that word. I'm like, whoa, that's a great way to put it. You should have different ways of doing things. So the first one, well, instead of bending down, that's a single leg deadlift right there. That's how a lot of golfers pick up golf balls, actually.
Really?
Yeah, Marty didn't teach you that. Second one, hip hinging at the sink. You can even get a little closer, or you can stand up straight and put a bib here, catch all that saliva.
You got that bib, don't you? You got that teeth bib, don't you? Brushing teeth.
I mean,
bib.
This might be personal, but I stand up straight when I brush my. I don't know why I need.
So you
to
got
look at the sink.
all that stuff leaking from your mouth.
I don't brush my teeth that sloppy, dude.
And then all right, I guess it's TMI. I revealed how I brush my teeth.
That third
don't judge
one,
me, guys.
That third.
Don't judge me, guys.
Oh, that third one's on the toilet, huh? It depends on my mood. All right. Like there's some days where I'm just like this. I don't know.
I don't think I sit in the toilet like that either. I mean, this is way TMI. But honestly, but if someone's having back pain, they probably should sit like that.
I'll
right?
say this: I never talk about how you sit on the toilet, but that's like a chair, basically.
Yeah.
You might be there from 1 minute to 1 hour, depending on your bowel movements.
That's another episode.
Shout out!
Don't shout them out. Don't shout them out.
The next podcast coming out, where we'll be talking about, other.
Let's try to stay away from this topic.
And then what's the other one? What's she doing? Washing dishes.
Washing dishes, or you know what? Isn't it kind of messed up, Stuart? That Mr. McGill or Dr. McGill, that all these people are women who are doing these tasks. We are not about that. There should be some men doing this. My fiance would agree with that. So
I'm not gonna get into that. I'm not a
So
part of that.
so, but let's get to the big three, because I think that sometimes I dumb it down, right? I want to just say, hey, because Miguel always, his whole thing is you just do these three basic exercises, and you should have a relatively pain-free. I know that's an oversimplification. How about you just walk us through these, and are these like the panacea where anyone just does these three and they're going to be good, or just walk us through your because you always say it's nuance, right? It's nuance, right? So give us some nuances that you're thinking about when you see these exercises.
The first one's a curl up. Looks like with one knee bent, right? And then the second one's a bird dog. We talked about that. It's supposed to help your multifidi muscles. Third one's a side bridge or side plank. In different ways, you're strengthening in that frontal plane. I mean, they're all great exercises. I don't know that these three can help everybody for every situation. And I know, I think I had his book and I looked at it, and he prescribed like 10 reps for 10 seconds. That can matter too. The duration of how long you hold things,
Walk us through that.
etc.
Walk us through what do you mean these, like, for me, I'm like from the old school mentality, like 4 sets of 10 for most things. But I mean, I don't have much evidence behind that. And there's a lot of research on this stuff. I think the researches could be all over the place, and it's hard to really measure this stuff because I mean, what's the endpoint? What's the outcome? Are you really just measuring muscle hypertrophy, stability? I mean, it's hard to measure these things.
I mean,
but what's a good, our audience wants some simple factoids. Do it for the gram.
For the gram.
What does the gram want to hear about the exercises and the reps? Everyone asks about how many reps.
Yeah, well, it depends on what you're trying to do. You can look into like basic strength and conditioning, right? Lower reps at high loads if you're working power. There's a range for strength and hypertrophy. You'll see different literature. It might be like 8 to 10, 8 to 12. And if you're trying to work muscular endurance, it would go beyond that. And then, you reach a certain point, you're not going to get benefit from doing like 50 reps of something. Probably your form is going to be sloppy. But you're really, again, it depends, because if you're doing a side bridge and the recommendation is whatever 30-second holds for 3 reps, you'll see that a lot. But if you're starting to lose your form there, and then overcompensate with other muscles, you can have an injury if you can't handle that. So you really have to titrate that amount. And I always tell people, like, when you go to your therapist, I'm not going to just give out any number there, because every therapist is going to give you what's right for you, or they should. And they really should be there to see what you can handle and progress and regress the exercise to the capacity, to the load that the individual can handle. I mean, these are great things. There's a lot of other things you can throw in there. This looks at stability. But we like to look at the person as a whole. Like, there's also range of motion and mobility exercises that can help people too. But
so
right there,
I think it's an important thing. Like, so sometimes as doctors and surgeons, we just give exercise packets, right?
Yeah.
And I think from what I'm getting from this episode so far is, honestly, those podcasts are probably not. I mean, not podcasts. I mean, those packets are probably not the most helpful thing, because patients might go out and do them and do them the wrong way, have the wrong form. They might, the reps might not be right for them. So I think it's just hard. It kind of goes to the main point. If we're trying to fix your mechanics and fix your back and prevent back issues, you got to see a specialist to kind of go over what your limitations are, right?
Right. I get it. And you're trying to help people by giving them something they can do. The simplest things you can do are the low hanging fruit, like activity modification. I think that goes a long way. But I have had people come in and try some of these on their own, or something they saw on YouTube, and do it also completely wrong, and then come back in more pain. But yeah, it's, people trust you as their surgeon, their medical doctor. So it's great that you can say, hey, these could be some things that could help you. But definitely see somebody who can walk you through these, and maybe see if there's something else that might be more appropriate in your condition.
Mm-hmm.
Yeah.
So one thing that I wanted to kind of talk about, I think it's really important, is I think a lot of people these days are jaded by their visit to physical therapists. I can't tell you how many times a patient comes to me and it says, well, I saw a therapist, they gave me a couple exercises, and they said to kind of watch me, and I was doing stuff in the corner by myself, and I'm not going to go back to therapy. And they don't believe.
Yeah.
And I think that the problem is it's not the therapist. I think it's the system because, as you know, insurance companies are squeezing clinicians. And I think that the therapists are being hit the hardest because they're not valuing the service that a therapist does. And I think a therapist should really spend a lot of time to try to understand what's going on with you and really try to cater a treatment plan that's really geared towards you, right? What do you notice in like the physical therapy community right now with all this insurance stuff?
Yeah, reimbursements get lower. There's times where they'll reimburse PTs for less than what you would get even in a training session with a personal trainer. Not to knock on any of them, they're really great. I used to be one, and but when
You
you're
used to be
doing
my
that,
personal trainer.
that's right. I used to train. When are we gonna
We
start
did
up
Muay
again?
Thai, yeah, a Muay Thai thing, right? But we got to get back into that.
Let's
All right.
do it. But yeah, so a lot of PTs who really value their own skill and their patients and want to give the best level of treatment opt to go out of network where they're not constrained by these limitations and can work with uh, patients on a one-on-one basis. And that you're seeing it trend that way more and more. And I think after COVID and everything, people are valuing their health and what they're putting into it. I mean, people already pay for massage trainers and they're seeing the value in going that route. I think it's important that everybody just finds what's right for them. Be it PT or the surgical route or whatever. Everyone's different, and I think it's just important to, value your health nowadays.
Yeah, I think bottom line, if you go to a therapist and you're not happy with your experience, there's another therapist probably you can find who can probably meet your needs. So
Yeah.
I think don't settle with the therapist that's not going to spend too much time with you. Make sure they care and they're invested and they want to see you get better and they're not on their phone while they're while you're doing the exercises,
Right.
because that's probably the biggest red flag, right? If you're on the phone looking at your IG or whatever, your LinkedIn or whatever social media thing you're looking at, and the patient's doing
Phones.
exercise.
We'll go into phones.
Yeah,
too.
text neck. We're going to talk about text neck at some point.
If they are on their phone, make sure at least they're doing it with
Good posture, right?
posture with the phone.
Neutral spine, guys. It's all coming back. Neutral spine.
But
So-
hey, yeah, wrap things up for us. I mean,
Yeah,
we're
so I
out of
think
time.
we're kind of running out of time right now. So I think bottom line, that's the key points from today's episode. All right, make sure you understand the mechanics of your back, because if you understand the mechanics of your back, you're less likely to injure it. So understand the discs, understand the muscles, how they all work together, and try to prevent the issue before it happens. Number two, make sure that if you do have back issues and you're trying to fix it naturally, you find a good therapist who's going to spend time with you to make sure that you're getting the care and attention you need. And I think that's all we have for today, right? Anything else you want to add to that?
There's so many more topics we're gonna go over. I look forward to it because this has been a good conversation.
Yeah,
'Cause we
it's
hang
good.
out but we never really go into it that way when we're off work. But it's I think it's good for people to know. I don't want to. I'm always preaching certain things when I'm working with my clients and patients, and I think I can reach a larger. We can both reach a larger audience and just educate people. That's really it.
Yeah, that's what this podcast is really about. It's about trying to take the information that we've accumulated from all these years from like different fields and make it accessible to you. That's what patients really just want. They want to be able to understand what's going on. And I think that's what this is an opportunity, because sometimes we might not have like the whole time to explain, go into all this detail, but that's why you can hit the like button, hit the subscribe button. See,
And share it with
Share
somebody who could use some of this info.
Share it.
Follow us on social media.
follow us
right
on the
down
social media. I
below.
think we're going to figure out how to put the social media there. All right, that's all we got.
Stay tuned.
All right, low five. Take it out. Close it out.
One, 2, 3, bam. You do it.
And it wouldn't be YouTube if I wasn't able to shout out our sponsors. Snogs Footwear, the footwear that was created for the healthcare hero. And you can find that right down there. Go to wearsnogs.com. And I'm going to shout out the Technique Physical Therapy out in Berkeley, where you get specialized physical therapy. Everything we talked about, you can find with Dr. Rob Lynn.
Yeah, we specialize in working with active people. I've worked with professional athletes, a lot of fighters, college basketball teams in the past. So, and even people who want to go that route and just don't know where to start, we just take you from the beginning and figure out how we can get you there. We're trying to make people live their dreams